Thank you so much, Jan, for your introduction. Yes, as everyone has appreciated, and by the flavor of the previous talks, the discussion today is really about individualized approaches. And I would like to talk about the use of brain physiology monitoring during cardiac arrest to guide resuscitation in patients. So we've talked a lot about patients who are in shock. And as Jan alluded to earlier, cardiac arrest is the most extreme form of shock. And for those who are involved in this field, I think that we would all agree there are different facets to cardiac arrest. There are different areas that we can look at. One is sort of understanding what are the factors that lead to patients going into cardiac arrest, predicting those, and trying to identify patients who may have a better chance of response. Really, ideally, moving on to sort of a personalized approach to treatments rather than just to the one-size-fits-all that we have. Moving on to the concept of resuscitation itself, we are all ingrained with CPR, but recognizing that CPR is 60 years old and is very much, again, a one-size-fits-all that probably needs to be altered and modified. And I want to sort of touch on a little bit about one of the issues here, which is that we don't really use a monitoring system to understand how effective the resuscitation is, whether with CPR or anything else, in terms of getting blood into the brain and perfusing the brain and delivering oxygen to the brain. Because, of course, as we all know, one of the biggest concerns is patients who end up with severe brain damage as a consequence of oxygen deprivation, and then particularly the reperfusion injury that occurs. Other aspects that I'm not talking about today, of course, is understanding what happens to consciousness during cardiac arrest. But again, that would be related to the quality of brain resuscitation, because clearly people who survive are more than just the sort of a number. They're more than just a brain outcome. There's also the psychological outcomes that they have and the consequences that come from that. So here I'd like to go and focus on this part of the talk, which is how can we understand the physiology of cardiac arrest better and use it to improve patient outcomes. I just want to sort of touch base a little bit about the current situation with cardiac arrest and why this is important. If you take, say, 100 people who suffer a cardiac arrest, what you find is that in general, with current CPR practices, we can restart the heart in about 40% of cases. So roughly 60% of people die in the first phase of a cardiac arrest because we cannot restart the heart. But interestingly, of those 40% who are initially saved, 75% of them die within hours to days in the hospital, in the intensive care unit. And this is due to secondary reperfusion injuries and complications that occur, but that actually you end up with roughly only 10% survival. Anyone who thinks that survival in in-hospital cardiac arrest is higher, I appreciate you reading the numbers that are published, but actually it's not really correct. People think that in-hospital is about 20, 25%. It really isn't. If you take out the people who have had just one quick round of CPR, one quick shock, many times, remember, all the people who've had their even a few moments of CPR started go into the data. But actually, if you look at people who have more than 5 minutes of CPR, what I would call proper cardiac arrests, who have not responded, survival is no more than 10%. It's not much better than the community. So that's the reality. And we want to find a way to improve this, shift these curves both upwards so that you can have more survivors. This slide is a little bit busy. I'd like you not to look at this left-hand side, but just focus on here, because I want to explain the pathophysiology of what happens in cardiac arrest that leads to that sort of 75% of people who die after the heart has initially been restarted. What we do know happens is that when you reintroduce oxygen back into the brain, the cascade of injury that occurs leads to significant heart, brain damage, and so on, which essentially leads to multi-organ failure and death. And so this is marked by this concept of reperfusion injury. I'm not going to go into more detail in this talk. But what I do want to point out is that there's another process of damage that occurs, which is that actually with the brain, that when you look at cerebral blood flow in patients, what you get is, if you imagine somebody who's had a cardiac arrest, before they have a cardiac arrest, they have 100% blood flow to the brain. It's normal. Obviously, it drops with the heart stopping close to zero. If you start CPR and do a great job, it's about 15% of baseline. But importantly, it's here that I want to point out what occurs. initially, as you can imagine, you get a period of reactive hyperemia. So if you restart the heart, then blood flow doubles up for about 30 minutes or so, as we know physiologically, in any situation where the tissues have been deprived. But then what happens is this, look, blood flow drops down to about 50% of baseline, and this can go on for more than a day or longer. And this is a period of delayed hypoperfusion. This is because there is intense vasospasm in the distal vasculature in the brain. And as a result of this, patients do end up with significant brain damage that is separate to the concept of reperfusion injury. So there are two mechanisms. And so what we really sort of appreciate here is very much that the concept of cardiac arrest actually is that what's new in cardiac arrest is that the damage that occurs is not so much from the anoxia, the ischemia initially, directly. It's actually the consequences of the ischemia when the heart has been restarted, which leads to either reperfusion injury, but also cerebral vasospasm. So I try to use this cartoon, is I think of an earthquake and a tsunami. An earthquake is bad, of course, but most of the damage, if you remember from the Japanese earthquake, actually occurred from the tsunami. And so we need to find a system that will help us to reduce the magnitude of the earthquake, so you don't get injury here, but also by reducing the magnitude of the earthquake, you will also reduce the magnitude of the secondary injuries or the tsunami. So you need a system to do both. Unfortunately, this is a Zoom call, and so we can't be interactive as much as I'd like to. But I'm going to put a question out to all of you who've managed cardiac arrest. How often are you able to detect what you're really doing and then make a change? And I think the answer is you probably don't really. You don't really assess what's going on in the brain as you're resuscitating that person. And that is the problem. Because without knowledge, how can we make any changes? How can we sort of provide personalized medicine? How can we use physiology if we don't really know what's going on? So to show this a bit better, let me show you then what we're talking about here is that, again, think of that sort of earthquake, think of the concept that there is a certain degree of brain damage that occurs as blood flow drops to the brain, as we all know this. And usually the threshold that's used is about 20 mLs per 100 grams per minute of brain tissue. But the concept here is that think of it as a gauge that you could adjust. If you could measure what's happening during CPR, during resuscitation, if you're falling below, like you do when you're driving a car, if your gas gauge, if your petrol is going down, you're not going to just keep driving, you're going to do something to fill it up. So here you want to sort of adjust this up and keep it as high as possible so you can reduce the consequences, the downstream consequences for your patients. And exactly, reach up to a higher level. So what I'd like to then introduce you now to is a system that I believe will be very helpful for clinicians. I've been using it for many, many years, as have a few other people, which is to use cerebral brain oxygen monitoring, cerebral oximetry. For those who might be less familiar, this is a system that essentially is non-invasive. It's very simple. It's a sensor that you can put onto the forehead, as you see here in this picture. And what it does is it provides near-infrared light, 2 different wavelengths. One of them penetrates the skin, the skull, and the dura. And the other goes deeper into the frontal lobe of the brain, about 3 centimeters, and actually measures the amount of oxygen in the front of the brain, second by second, and gives you feedback as to exactly what's happening. The devices, there are many of them commercially available. I won't be talking about specific ones, but just to say the devices use an algorithm to tell you how much is actually, they subtract what's in the skin, the skull, the dura, and actually tell you what's going on inside the brain itself. And that's what's key here. You may ask, how does it work compared to pulse oximetry? And the reality is that unlike pulse oximetry, the traditional ones that we use, it does not rely on pulsations. So you can put it on the brain during cardiac arrest and actually get an accurate measure. Because our time is short, I won't go through much in terms of history and other studies that have happened, but just to point out that to sort of show you the results of a study that we completed in 2016, that was published in Critical Care Medicine, that unfortunately I think you can't see the bottom here, but the reference is there. And what you can see is that If you use brain oximetry during cardiac arrest, you can get a very strong predictive of which patients will have their hearts restarted. So if you see here, this was a study with 183 patients. You'll see here the interquartile range and the median for brain oxygen levels during cardiac arrest for patients whose hearts did not start. This was 121 people. What you can see is that the median is roughly 35-40% here. And then you see there's a relative stepwise increase in the oxygen levels in people who initially had their hearts restarted. So this is the 40% or so whose hearts do restart. But then unfortunately subsequently died. So unfortunately they're within the 75% who did die after their hearts were restarted. And then compared to those whose hearts were restarted and who survived and left the intensive care unit and the hospital alive, without significant brain damage. You'll see this sort of stepwise approach to almost like a dose response curve to the oxygenation that was achieved during cardiac arrest. And so we think that is basically reflecting better perfusion, better tissue oxygenation delivery, allowing the heart to restart, but also reducing the magnitude of injury later. Just to show you, is this static? It absolutely is not. It's a highly dynamic measure. If you put it on patients, you'll see measurements that are very, very accurate, and that it responds to things that you do. Here is the results of a small study that we carried out almost 10 years ago now, that was also published in Critical Care Medicine, where we actually looked at the difference in brain oxygenation in people who were resuscitated using manual CPR compared to those who were resuscitated using mechanical CPR. And what you see here clearly is a very significant difference in the amount of brain oxygen that was achieved in people with mechanical CPR. I just want to also point out here that you'll see how this sort of moves up and you can measure it very accurately. So you'll see here with manual CPR, the sort of overall average levels of brain oxygen that we get is about 35%. And in people with mechanical, it's about sort of 55%. Now, one thing I forgot to mention, and I'll bring it up here, is what is the normal brain oxygenation that we would want? Remember, what you're essentially measuring is like a mixed venous oxygen saturation of the brain. So what you're really getting is you have normal values are going to be roughly 70% because it's the difference between the oxygen that's been delivered to the brain, let's say 100%, and 30% that's taken up by the tissue that is functioning. And so you're left with about 70%. And when you're in profound shock, the oxygen levels drop very rapidly. And so often in cardiac arrest, they might be as low as sort of 10 or 15%. And you'll see here, these are pretty low. When you provide CPR, you start to see an increase in those levels. And what you see here now is essentially what happens when you do manual CPR compared to mechanical. You get about a 10% increase. To show this better for you, this is a case of a patient whose resuscitation I was involved with. You'll see here that this was actually a patient who had a cardiac arrest in the cath lab. And so by the time we were called, manual CPR had been ongoing. And so when we put on the brain oxygen monitor, you'll see that we were measuring something in the 30s, mid-30s, you see, with manual CPR. And then what I'd like to show you is that when the patient was switched to mechanical CPR, there was about a 10% increase in the brain oxygen levels. And this was what led to a transient return of spontaneous circulation. You'll see that the heart restarted here transiently. The oxygen levels went up. Unfortunately, the patient was unstable. They lost the output. They regained it again. And at the same time, we had started ECMO, or we're starting ECMO. The patient was being cannulated. And this is what happened when the ECMO was actually started on the patient. You'll see the brain oxygen shot right up to completely normal, 70%. This shows you the dynamic response that you get if you use brain oximetry in patients. The other thing I'd like to show you here is that if you bear in mind what was happening here, this person had had about an hour and a half of resuscitation by the time they went to this point. And actually, interestingly, you would have imagined this person would have ended up with severe brain damage. But actually, about 3 hours, 4 hours later in the cardiothoracic intensive care unit, this person woke up and started pointing to the ET tube, asking for it to be removed. So I think what you see is the concept that by increasing oxygenation during CPR, we also probably reduce the longer term consequences. I'm going to rush through these other slides, but just to say that you'll see here a larger study that we have just completed. This is not yet published, but I just want to show you the concept that it's showing. This is in almost 600 patients now, and you can see very clearly here the same model that I showed you in the previous study, where essentially patients whose hearts do not restart, although there's a fairly wide distribution of the oxygen levels, each dot is a single patient, you will see here that clearly the median levels in people whose hearts do not start are lower in a dose-response way compared to those whose hearts start, but then subsequently die, and then those whose hearts start and live and leave the ICU. The one thing I do want to point out here, which may not be obvious, is that if you look at this group, which is a group we're really interested in, the people who do survive, whose hearts are restarted and who survive and leave the hospital alive, what you see here, which is interesting, is look at the lower level. There is nobody in this group who actually, even the outliers, who had a brain oxygen level less than about 30% during their resuscitation. And when you compare that, if you look at this slope, there's clearly a sort of a line going up here. And you'll see the people who did much worse, whose hearts did not start, were actually much, much lower. So there is a certain minimum level of brain oxygen that you seem to need during your cardiac arrest to ensure that not only does your heart start, but that you also end up leaving the hospital alive. You also see that it's much tighter. There's a much tighter range in terms of what you get. We also looked at this data by examining the relationship between the period of time. Remember, I said to you that the normal brain oxygen is 70%. Clearly, it's very difficult to achieve a completely normal brain oxygen to deliver the absolute perfect brain oxygenation during cardiac arrest because of the profound shock the patients are in. So we took a cutoff of 50%, i.e. something that's lower, but not exceedingly low, to see whether that has a good predictive value for whether patients live and have a good outcome. And what we were particularly interested in is not an absolute, not a moment of 50%, but actually the overall relative period of time during the cardiac arrest that patients spent above 50% as a threshold. So recognizing that you may get dips, but what overall percentage of time were you above 50%? And what you see here is patients whose hearts never restarted actually spent very little time. So this is a percentage of time the brain oxygen was above 50%. And you'll see that again, the trend, if you look at the mean, is very low periods of time above, overall. They may have achieved it for short periods, but overall, they weren't able to sustain it. And if you compare that to people who live, you see here that essentially they spent about 60-70% of the time above 50% as a cutoff of brain oxygen. And that is what seems to be very highly predictive of patients leaving the hospital alive. And you can actually use this to create a diagnostic test that's pretty sensitive and specific if you use it appropriately with the appropriate cutoffs, i.e. that you have to achieve at least a 25% cutoff as a bare minimum, but really that's the bare minimum. You need to try to target your brain oxygen to 60-65% if you can, or at least maintain it above 50%, okay? And then I just want to just sort of point out very quickly that actually these kinds of data can now be used using machine learning algorithms where you can put in all kinds of patient variables, age, demographics, different physiological parameters, and different trends of the physiological parameters that are going on to see whether you can create a better predictive system. And just to say that as you do that, what we found is that what stands out in spite of, hundreds of data points that go in there is that actually the overall, this is what's called the mean first derivative. It just means the overall trend, whether the brain oxygen is progressively going up or down, that if your brain oxygen is progressively going up during cardiac arrest, this is much more likely to predict the ability to restart the heart. And if your brain oxygen is going down, your probability of getting the heart restarted is only 19%. And then you can add in other variables into that to be able to predict accurately whose hearts will restart and who will not. You can also integrate that with end-tidal CO2 monitoring systems and again, come out with some sort of machine learning algorithm. I don't have time to go into in detail, but just to say that, again, if you put in all the different variables patients have into your model, you will still find that the overall increase in brain oxygenation is the highest predictor of whether patients' hearts will restart. But you can integrate that, and it's synergistic and helpful to combine that with end-tidal CO2 because they measure two different things. And so finally, I think looking at the concept of physiological-driven resuscitation, this brain-targeted resuscitation, is to recognize that we don't treat anything else in medicine as a one-size-fits-all. If you have a patient with septic shock and they still remain in profound shock, they're still febrile, and their white count is high, CRP is high, you don't continue with the same antibiotics. You increase your treatments. If you're an asthma expert and you have a patient coming to a clinic, even as an outpatient, and they're getting more asthma symptoms, you don't just keep giving them inhaled corticosteroids, you may increase the treatments you're going to give them. So here, the same concept I think applies to resuscitation. We should start patients with cardiac arrest as we do with ACLS, but importantly recognize that if after 4 or 5 minutes, if the patient's heart has not restarted and your brain oxygen is less than about 60% and your end tidal CO2 is less than about 40%, you need to do a stepwise approach. So that may mean just don't do the same thing, because if it didn't work in the first 5 minutes, it's unlikely to continue to have some miraculous effect 15, 20 minutes later when the patient is sicker. So you need to think of this stepwise approach. It might be to augment mechanical CPR to get a bit more tissue perfusion. It might be to adjust your pressors. There's a lot of discussion about what is the right pressor, what is the right agent. Should we give it singly 1 milligram of epinephrine? Should we give higher dose of epinephrine? Should we combine that with vasopressin? Should we add steroids to patients during this? Should we do a straight leg raise? There are other devices like an impedance threshold device, and there are even other modes of CPR, which I don't have time to go into, but the concept being you should be augmenting this. But at the very end, if you're not able to get this up within about 15, 20 minutes, then recognize that you probably need to go for an eCPR or an ECMO consult to restore cerebral perfusion and organ perfusion, but do that early rather than late. And so to sort of end, my final slide is, what is the utility of brain oxygen monitoring? One is that it is highly predictive of return of spontaneous circulation. And we think, you may ask, well, why is it predicting for the heart restarting? And I think you just have to appreciate that if you're measuring what's going on in the brain, then you're probably also acting as a surrogate for what's happening in the heart as your coronary perfusion pressure, which is what's needed to restart the heart. And as everyone knows, that is a very important variable in the ability to get the heart restarted. We need to target at least 50, but the best coronary perfusion pressure is reaching up to about 40. Again, it's a stepwise approach, and I think this is giving you an idea of where you are with that. It seems to be contributing to the ability to have patients live and have important, significant or normal brain function at the end. Clearly, there are many other variables that come into the ICU that relate to that, and it's you can't have a single thing, but I think it is a very important one. And it's giving you essentially a GPS look into the body. In terms of those who may be less familiar with it, there are numerous devices out there. They're not particularly expensive and they can be used. It doesn't have the limitations of end tidal CO2, which in a nutshell is the end tidal CO2 is measuring your circulation through the pulmonary artery. But again, what you're measuring as the end tidal CO2 reflects what's happening in the lung. A lot of these patients have pneumonia, they have COPD, they go into pulmonary edema. And so you may be getting an artificially low end tidal CO2 measurement that is not reflective of your quality of your circulation, first. Secondly, it doesn't tell you anything about tissue perfusion. It doesn't tell you how much oxygen is actually getting into tissue. And that's why I think these two are synergistic. And again, I think we need to recognize to use these in a sort of a physiological manner to improve our treatments in a stepwise way. And with that, I will end. And I thank you for your time and to all of my colleagues and organizers who helped with this.